Great, thanks so much, Steve. It's really a pleasure to be here speaking to everybody, and in particular the nurses work group, because I think this is obviously a group that is incredibly essential to the management of cardio-oncology patients. And I think it's an evolving area in terms of what really defines cardio-oncology nursing, but really one that I believe is going to be truly essential to having any really functional and integrated cardio-oncology program. So I was asked to give a brief talk on cardio-oncology, the past, present, and future. So to give a little bit of a idea of where we've come from, where we are now, and perhaps where we may be going, at least from my perspective. And I also wanted to ensure that we talk a little bit about how nurses fit into this conversation. So these are my disclosures. So the objectives for my talk today are a fewfold. First, I want to discuss the historical evolution of cardio-oncology as a subspecialty of medicine, discuss what we've learned in some of the current knowledge gaps, discuss future research directions in cardio-oncology, and then really discuss the importance of a multidisciplinary approach in the continued growth and development of cardio-oncology as it relates to nursing. So as all of you know, cancer and cardiovascular disease represent the two most common causes of mortality in the United States. About 1 in 3 adults have some form of cardiovascular disease. And there are around 12 million cancer patients, but what you may not recognize is that there are even more cancer survivors. Currently, it's estimated at around 14 million cancer survivors, with that number expected to increase substantially over the course of the next decade. About 30% of patients receiving cancer therapy will have some type of cardiovascular complication, and that can either be the exacerbation of underlying disease or the development of a new problem. And this can affect patient survival and quality of life independent of their oncologic prognosis. And some complications may not become apparent for 10 to 20 years after the completion of their treatments. So I want to start off discussing the past. And I think that when we think of the past of cardio-oncology, we really associate it with heart failure. Now, that's not to say that heart failure doesn't have a prominent role in the present and the future of cardio-oncology, but heart failure is certainly where the field first developed. We have known that anthracyclines can lead to heart failure since the 1970s, and dose clearly matters, with a significant increase in toxicity at cumulative doses of more than 450 milligrams per meter squared. The recent ASCO guidelines consider high risk for cumulative lifetime doses of more than 250 milligrams per meter squared, or less than 250 if other cardiovascular disease risk factors are present. Now remember, anthracyclines are a common part of many different cancer treatment regimens. So anthracyclines are used to treat breast cancer, leukemia, lymphoma, sarcoma. So, you know, a lot of our patients are going to be exposed to anthracyclines. And historically, anthracycline-induced cardiomyopathy was thought to portend a worse prognosis than other forms of non-ischemic cardiomyopathy. However, more recent data suggests relatively equivalent outcomes. And the thought was that some of these older data may also be related to cancer-specific mortality as a competing risk. The median time to the development of heart failure symptoms is about 7 years, with younger patients having a more delayed effect, whereas older patients tend to develop their problems more quickly. For example, in a study from Daniela Cardinale, 98% of subjects developed cardiovascular issues in the first year after treatment, likely because of the additive effects of underlying cardiovascular risk factors in conjunction with the anthracycline exposure. Now, with the introduction of targeted therapeutics like trastuzumab, the survival for HER2-positive breast cancer was significantly improved. But again, just like anthracyclines, heart failure was identified as a serious side effect of the drug. So this was a study by Slayman and colleagues looking at 3 different breast cancer treatment regimens. And there was a significantly higher sustained reduction in the ejection fraction in patients that were treated with the ACTH group. So that's the group that received anthracyclines as well as trastuzumab. And that number was around 18%, compared to 11% in those patients that were treated with anthracyclines alone, listed as the ACT group, and 9% in those treated with trastuzumab alone, the TCH group. But it's important to recognize that the absolute ejection fraction generally remained in the normal range in this study, and clinical heart failure was still rare, about 2% in those treated with trastuzumab and anthracycline, so that ACTH group, compared to less than 1% amongst those patients treated with anthracyclines alone or trastuzumab alone. And we know that timing matters regarding trastuzumab-induced heart failure. Reports in the literature range anywhere from under 1% to more than 20%. And the rates were highest in the metastatic trial when anthracyclines were given concurrently with trastuzumab, and that was reduced to around 0.6% in the HERA trial, in which there was a 90-day window between anthracycline dosing and trastuzumab dosing. It's through these data that we've actually moved away from giving anthracyclines to the majority of patients who have HER2 positive therapy, and really reserving it only for a very small specific subset of individuals. And getting rid of that anthracycline component really minimizes the risk of heart failure with trastuzumab. And then heart failure was also something that everyone was talking about with the advent of the small molecule tyrosine kinase inhibitors. So in 2001, the development of imatinib revolutionized the treatment of chronic myeloid leukemia and led to this paradigm shift in the approach to cancer treatment in general. And as a result, CML is now primarily treated with tyrosine kinase inhibitors, and this targeted approach to cancer therapy is really kind of the focus of most of the clinical development of cancer therapy, along with the development of immunotherapy. And imatinib became the standard of care for CML based on the results of the Iris study, which compared imatinib to cytarabine. And at 5 years, there was an over 90% hematologic remission and 80% complete cytogenic remission. Now in Iris, there were some reports of lower extremity edema, but no definite cardiotoxicity events were reported. But then in 2006, Thomas Force and his colleagues published this very provocative paper reporting the development of cardiomyopathy and heart failure in mice that were treated with imatinib. Now, it should be noted that in this study, the amount of imatinib that was given to the mice was in far excess of what humans normally receive, but nonetheless, it really was a thought-provoking paper and really was another one of these kind of foundational moments in the development of cardio-oncology. Now, subsequently, a study reviewing the clinical data from over 1,000 imatinib-treated patients at MD Anderson really has kind of moved towards refuting this initial claim, and there really doesn't seem to be a significantly increased risk of cardiotoxicity with imatinib, though other TKIs to treat CML, we are seeing these issues. And for example, we also see heart failure as an issue with the TKI sunitinib, which is used to treat primarily renal cell carcinoma. And you can see from this forest plot that the relative risk of all grade and high grade heart failure events associated with sunitinib versus control was 1.8 and 3.3 respectively. So clearly, heart failure as a disease process dominated the initial parts of the developed the foundation of cardio-oncology. And so with that in mind, it also led to some conflict between the cardiologist and the oncologist and who is really responsible for managing these patients. The oncologist gives their cancer treatment and the patient developed heart failure. Well, now did it become the cardiologist's responsibility to treat and manage? Or was it the cardiologist, who saw the patient and said, well, this was all because of their cancer in the first place, you just need to manage their cancer. And that's really something that we wanted to move away from as the field of cardio-oncology developed and moved to a much more collaborative, multidisciplinary approach to the treatment and management of these patients. So I think that's a nice segue into the present. So where are we right now? So you can see here the evolution of cancer therapy. We started off with the anthracyclines back in the 1970s, and then we moved into trastuzumab and the anti-VEGF therapies. And again, all of this really was focusing primarily on heart failure.
Yeah,
but then
we don't deal with any of that, like an EC thing, so you would have to check let's see, for them.
Then we moved from anti-VEGF therapy in the 2000s. We moved into the proteasome inhibitors, the checkpoint inhibitors, and CAR T therapy. And it's through this evolution of cancer therapy that we've really become to understand that there are quite a few different cardiovascular complications that can occur as a result of cancer therapy. And again, while heart failure is still very important, it really is just the tip of the cardiotoxicity iceberg. And with so many of these newer agents, we're recognizing anything from arrhythmias to myocarditis to vascular diseases like ischemic heart disease and strokes. And so we really need to think broadly and recognize that cardiovascular complications of cancer therapy encompasses the entirety of cardiovascular disease. And this is important to monitor for and to treat cardiovascular complications because patients with cancer are living longer and in many cases surviving their disease. As you can see from this chart, the 5-year survival rates for many cancers has increased significantly over the last 3 decades, with some approaching 100%. And some cancers are now being approached as chronic diseases, something like chronic myeloid leukemia. So the last thing we want is for cardiovascular disease to become a barrier to receiving effective cancer treatment, or to survive cancer only to be left with lifelong debilitating cardiovascular complications. And we know that cardiovascular disease is quite common after cancer treatment. These are data from the Childhood Cancer Survivor Study at St. Jude's, looking at more than 10,000 adult survivors of a pediatric cancer and compared them to their sibling controls, which therefore tried to control for things like environment and genetic factors. And the incidence by age 45 of coronary disease, valvular heart disease, arrhythmias, and heart failure was significantly increased compared to the controls. And then when you look at serious life-threatening coronary and heart failure events, the incidence at age 45 was 5.3 and 4.8% respectively. Similarly, cardiovascular risk factors are far more common in cancer survivors, with hypertension being the most common and most associated with the development of frank cardiovascular disease and overall mortality. And we know that cardiovascular disease mortality risk is highest in survivors diagnosed at an age under 35. And cardiovascular disease mortality risk is highest within the first year after cancer diagnosis, especially amongst patients that were that had a diagnosis of endometrial cancer, at least in this recent study that was published in the European Heart Journal. And cardiovascular disease mortality remains elevated throughout the follow-up period compared to the general population. So particularly, cardiovascular disease mortality is important not only early in the diagnosis of these patients, but also in the long term amongst survivors. And particularly in the survivorship population, this far exceeds cancer-related death or secondary cancer development. In this particular study, the majority of deaths from cardiovascular disease occur in patients diagnosed with breast, prostate, or bladder cancer. And we observed from the point of cancer diagnosis forward into survivorship, the cancer patients at all sites are at an elevated risk of dying from cardiovascular disease compared to the general US population. And we recognize this risk is likely present because cancer and cardiovascular disease have many shared risk factors, things like tobacco use, obesity, physical inactivity, poor nutrition, alcohol, and diabetes. And because of that, many of the factors that contribute to the development of cancer are likely to ultimately contribute to the development of cardiovascular disease down the road. But I think it's also important to remember that these shared risk factors go both ways. And there's increasing data to suggest that some of these cardiovascular disease risk factors, patients who get identified with cardiovascular disease, may also have higher incidence rates of cancers. So it's an opportunity also to think about our cardiology patients in general and think a bit about whether we need to be very aggressive with screening for certain cancers as well. So with that being said, I think it's important to just kind of remember what a definition of cardio-oncology actually is. So it is a multidisciplinary field aimed at managing cardiovascular risk and preventing cardiovascular disease in cancer patients and survivors, with a goal to eliminate cardiac disease as a barrier to effective cancer therapy. And we've really seen, over the last decade, an explosive growth in the field of cardio-oncology, clinically, academically. So you can see here that we've seen this explosive growth of cardio-oncology publications. So the first publication to ever reference the term cardio-oncology was in 1996, and that was from Daniela Cardinale, who, as you all know, is really sort of the pioneer in the field of cardio-oncology. To today, in which there has been 1,948 publications referenced in PubMed since 1996 that have the search term cardio-oncology or oncocardiology in its keywords. And just in 2020 alone, there were 555 publications. And you can see in this nice little chart on the left here how the number of publications has increased dramatically over the last several years. And in keeping with that, we now have 2 journals in cardio that are dedicated to cardio-oncology specifically. There's the Cardio-Oncology Journal, as well as JACC Cardio-Oncology Journal, which has quickly become really the premier cardio-oncology publication, and one that is really where we are seeing some of the most high impact, high quality scientific studies published. What about education? So there's a lot of new opportunities for education. So you all are here on this Icos webinar, so you know about these, and these are really an excellent opportunity for people to become engaged and to learn in a relatively informal setting different topics. But there are also some well-developed, comprehensive educational programs that exist for individuals that are looking for a more comprehensive evaluation. And so those would be things like the ACC Advancing Cardiovascular Care of the Oncology Patient that happens annually in late January to February. And then of course there's the Global Cardio-Oncology Summit, which is in conjunction with Icos, and that tends to happen annually in September or October. Now, as we all know, with COVID, these conferences have all become virtual, but hopefully in the future we'll be able to go back to in-person meetings again. So I think that anybody on this call who's not familiar with these, this is really an opportunity to really delve much deeper into the area of cardio-oncology and have an opportunity to interact with a broad array of experts in the field regarding various different topics. And with that, I want to just give you all a reminder to come to VCOS 2021. So this is the virtual Cardio-Oncology Summit, September 30th and October 1st of this year. Again, because of COVID, we're unable to do an in-person GCOS meeting, so we've cleverly changed it to the VCOS meeting. But virtually, we will again have many expert speakers on a variety of interesting topics. And so I encourage everyone on here to register for that in the coming months. And that's going to be in conjunction with the Icos Society, as well as Penn Medicine, who will be providing the CME for it. For interested individuals, there's now Icos board certification. So as we move along and really kind of make this field a true subspecialty of cardiology and oncology, we are now offering board certification through Icos, and many members of the organization have already sat for the exam and have obtained board certification. So what about the future? So we want to expand our global footprint. I think it's incredibly important to look to the global community and what is being done from a cardio-oncology perspective outside of, say, North America or Western Europe. And I think that's important because how cancer care is delivered outside of the US, Canada, and Western Europe is going to be different. The treatments are going to be different, and how we approach complications in these patients is going to be different. So we've really worked incredibly hard, particularly with the leadership of Steve, to build our international representation and bring in chapters from around the world. And these are several of the chapters that currently exist. We certainly have research priorities. I think we're working towards the early identification of cardiac risk, particularly how we can utilize cardiac imaging or cardiac biomarkers to identify those individuals who are likely to develop different types of toxicity. And again, not just heart failure, but the full gamut of cardiovascular issues. And then from there, developing strategies to prevent cardiotoxicity. And I think that's really, kind of the holy grail right now of cardio-oncology is, we know these things can happen, but what can we do to prevent it? And thus far, we haven't been able to identify either the right therapy or the right population in whom therapies might be beneficial. We need to develop cancer-specific cardiovascular risk prediction models. We know that how we assess cardiovascular risk in the general population does not translate well into the cancer patient population due to these shared risk factors that exist that oftentimes amplify and augment one another. So how do we start developing prediction models that are unique to cancer patients and survivors? And then lastly, we really need to work on mechanisms of cardiotoxicity. We know that these things exist. We have a lot of good clinical data, but we don't always understand why they're happening. And getting to the root of why will ultimately help us to develop better treatment strategies, better risk prediction strategies. And I just put this image up here, which is a recently published paper on the potential mechanism of ibrutinib-associated atrial fibrillation, which is a topic that a lot of people have interest in trying to understand and identify. So in the last few minutes, I want to just talk a little bit about how nursing might fit into this. So the cardio-oncology nurse coordinator is something that I think is really important, and I think it's something that we all need to think about integrating into our cardio-oncology practices. And nurse coordinators can help to standardize care delivery through patient and staff education, care coordination, the triage of urgent cardiovascular issues, and the development of nurse-driven protocols. And all of this is going to lead to increased patient, provider, and nurse satisfaction, as well as going to things like nursing practice development, such as roles in AAON, which is the American Association of Oncology Nurses, or something that could be highlighted as far as magnet recertifications for different organizations. So this is an area that I feel pretty passionately about, and again, I think that it's something that we all need to kind of explore in more detail and figure out how we can incorporate nursing into cardio-oncology. From a patient education standpoint, I think this is an area that can become incredibly important for a nurse or a nurse coordinator in cardio-oncology, because this is the opportunity for the nurse to really interact with the patient as well as other providers to make sure that everybody is on the same page regarding the potential risks and what we're going to be doing for them, and specifically talking to the patients about their cancer medications and their impact on the heart, talking about some of the cardiac medications that we may be starting, and the patients may need a bit more education about that after the physician or the APP starts the medication. The nurse coordinators can really focus on diagnostic testing. What exactly are we doing? Why are we doing it? Again, these patients are oftentimes dealing with many different issues, have a lot of psychosocial stressors, and are getting a lot of different tests, and it's hard to always remember what and why they're doing things. And this is a great opportunity to ensure that patients understand and their caregivers understand what is happening. This is also an opportunity to talk a lot about prevention and lifestyle and really offer motivation and support to the patient. So we know that prevention, particularly from exercise and dietary changes, can have a huge impact in cancer outcomes and cardiovascular outcomes. And this is an area where, again, nursing can be really helpful in sort of checking in with patients and ensuring that they're motivated to continue focusing on heart-healthy lifestyles. And we know that nurse coordinators can impact outcomes. So it's not just that this is a nice topic to talk about, but that there's actual data to support overall benefits. So this was a study of a nurse coordinator cardiovascular prevention program. So not necessarily in oncology patients, but could easily translate into our cardio-oncology population, in which nurses provided general lifestyle and dietary advice, as well as counseling on smoking cessation, physical exercise, and in collaboration with a provider, treatment of their blood pressure and their lipids. And as a result of this nursing intervention, the 10-year cardiovascular mortality risk was significantly lower at 1 year in those enrolled in the nurse-driven program compared to the control patients. So you can imagine how this could really be an incredibly important benefit for our cardio-oncology patients, and something that not only could be implemented practically, but could also be studied academically. And I think from a future goals standpoint, we want to improve access to effective multidisciplinary care. We want to educate healthcare providers and the public. And I think that's a really important thing to remember. You know, in cardio-oncology, it's not just about talking amongst those of us in the medical community, but it's also really engaging the public. It's getting out there and ensuring that patient advocacy groups, provider, caregiver advocacy groups are aware of these issues and are ensuring that, you know, there's patient empowerment with regards to their cardiovascular health. We want to improve the application of guideline-based diagnosis and treatment. We want to commit to collective research in this field, and then ultimately share our experiences with our colleagues, and really form true multidisciplinary networks that include not only the cardiologist and the oncologist, but also includes nurses, advanced practice providers, nutritionists, exercise therapists, all of whom are really essential and integral in the cardiovascular care of the cancer patient. And again, nursing plays a very important role in achieving each of these in cardio-oncology. And finally, a couple of thank yous. I do want to give a shout out to Dr. Susan Dent for sharing some of her slides with me for this talk. So thank you if you are on, and if not, Dr. Dent is amazing. And then I do want to do a special thank you to Natalie, Bernadette, Julie, Ikea, who are the nurses that I've worked with in various environments who've helped to make cardio-oncology programs successful. And then, of course, all the nurses who are working tirelessly to make sure our patients are cared for and are really carving out this new career path in cardio-oncology, which I think is so important. And with that, I will conclude, and happy to take any questions, or kind of just have a conversation with anybody who's interested.
Well,
hi. Hello?
Go ahead.
Hi, Dr. Fradley.
Yes.
Thank you so much for that amazing presentation. My name is Vicki Chambers. I'm actually an oncology nurse educator with AstraZeneca, and I live in Florida, so I know that you are really, really missed from Moffitt Cancer Center, I'm sure. But my question was, have you been able to incorporate a cardio-oncology discussion or consultation from a tumor board? Have you seen that as an opportunity, or how does that fit in?
Yeah, that's a great question. So we have at Penn, we have an established cardio-onc tumor board that meets every other week, and that really invites any interested stakeholders to participate. And in that environment, we are basically talking about any patients that we think are complicated from a cardiovascular management standpoint, whether it's actually how do you manage it, or how do we diagnose it, getting people's opinions on whether or not we think that this is actually, say, cancer related toxicity. And an area that is very frequently discussed is checkpoint inhibitors. Do we think this patient's troponin elevation was actually because of myocarditis or something else? So we have developed that, and it's actually, I think, an incredibly beneficial conversation, and it includes individuals from all of the different Penn Medicine hospitals. You know, as far as the specific, then from an oncology perspective, we do try to attend some of the more targeted tumor boards that exist for the different oncology programs, at least the ones that we know are more likely to have cardiovascular issues that may impact the care delivery to these patients. So lymphoma, the leukemia and stem cell transplant group, breast cancer. You know, what I will say is that in you know, a few years ago, pre-COVID, it was often tough because, you know, everything was, you would hard to be able to get to all of these meetings. It's actually been a little bit easier to attend to them now that things are virtual, and you can kind of just put on the tumor board, even in the background, and just sort of be there listening and available for a targeted question if it pops up. So we're trying to also be involved as much as we can in that.
This is Carrie. Mike, may I just follow up with how in a community-based system, because that has been a huge success for us. So I'll just share that I work at Franciscan Health in Indianapolis. It's a major hospital system. There is 11, and we have this hospital and one in Mooresville. However, we have lots of satellites. We have approximately 15 tumor boards a month. And when I got in my position at the end of 2016, I asked if I could start going to the tumor board. So I went to every single tumor board. My face was present. I learned how they manage. And I just started, you know, I had oncology experience, but my cardiology experience was greater. And so, you know, it helped me start the dialogue with the oncologist and helped me extend my arm as, you know, I was a partner with my cardio-oncologist, Vijay Rao and Ryan Daly at that time. And it just started to work its magic. And pretty soon, you know, they were reaching out to me, or I would comment and I would say, you know, based on the cardiac risk score, I would recommend that you get a pre-consult. Or I would go talk to them afterwards. And pretty soon, the next thing we did was we did have cardio-oncology tumor boards. And I'll tell you that I feel like this is a good approach if you are a nurse who is trying to, you know, bridge that gap.
Hello?
Yes, please ask your.
Can you hear me? Oh, hi. I'm Veronica Santos from Brazil. Mike, congratulations for a wonderful presentation. And I am very happy to get close to the nurses. I am personally very, very friend of you. And my sister is living in a hard experience now, and the nurses there in Florida. They are very kind with her, and I'm very happy about it. I wonder if the nurses could be part of the main studies, Mike. I don't know if you agree with me, but sometimes we don't see them getting close into the real work of the big trials and everything. So I think we could be very much closer to them, because they are really our bridge and our manager in all aspects. What do you think about it?
Mike, are you muted?
No, I missed the last part of what Veronica said.
Veronica was asking if you, she was commenting that she feels that nurses are essential, and she's glad to hear this. And she was wondering if how we might bring nurses to be a part of research. And when you get done, I would like to make a few comments.
Yeah, so I think that that's incredibly important, and I do think that we need to be thinking about ways in which we can I think integrate more nursing research into cardio-oncology. Again, I think that a lot of what we have focused on so far has been on, you know, kind of mechanisms and a lot of the pathophysiology. And when you look at a lot of, you know, I mean, I think a lot of nursing research, you know, there's a lot of kind of practice development, a lot of topics that relate to you know, how we manage patients appropriately. You know, issues with, you know, caregiver relationships and delivery of information. And so I agree with you. I think that there are so many opportunities in which we can learn how to better manage and treat these patients by incorporating nursing expertise into different clinical trials, as well as developing studies that are really kind of focused on some of those nursing interventions themselves.
Thanks, Mike. I'm gonna, go ahead.
This is Agnese Maria, Cancer Institute of Bari, Italy. Congratulations for your deep and complete presentation. I have a question for you. Is there a difference in risk stratification for cardiotoxicity between solid tumors and hematological malignancies? I mean, should we manage in a different way a lymphoma and a patient with breast cancer? For instance, the total cumulative dose of 250 is the same for a lymphoma patient and for a breast cancer patient? Thank you.
So that's a really interesting question. And I think that to answer the first part of your question, which is, you know, do we have data that kind of specifically addresses whether we should be managing these patients differently? As far as I'm aware, we don't have that data. But I agree with you that probably the cumulative dose that a patient receives, there are probably cancer-specific risk factors that impact the likelihood of their long-term cardiovascular risk. Some of it's probably related to, you know, the aggressiveness of the cancer itself, but there are probably some other underlying genomic aspects that are probably contributing that would be very interesting to look into. So I think that's a really thoughtful and interesting question, one that all of my very smart scientific colleagues will probably start looking into soon. And I want to turn it back to Carrie, just because I know she'd wanted to touch briefly on the nursing research aspect as well.
So I love research, and I have always tried to get a part of it, and Cardio-Oncology has allowed me to do that. So we were blessed to be invited as a community-based center to do the SURVIVE trial. And when we first started, we have a very active cardiology research program and a very active oncology. And so, but they weren't sure how to mesh that because they weren't sure where cardio-oncology should lie. And so I think it ended up in the cardiology research, but the patients were in oncology. So myself and I have another nurse navigator, and we're going to hire another one. And I have an assistant. We all became research certified. And then we became the person on the oncology side and helped bring these patients in. And then we eventually, you know, moved it forward. So now the oncology and the cardiology group work collaboratively together because our workload has become so much, and it is really well done. I can tell you that from the word I hear on the streets through our nursing network, there is lots of nurses out there already starting to reach out. I think Anacita Fidel is actively working. I think in Nashville with Victoria Phillimore, who's one of our leaders, and she's working with Dr. Mosholy. I can never say his name right. You guys need to help me. And sometimes I have a speech problem, but and I can tell you that I am working with my team. We have, I was blessed to be able to get the cardiac risk in the EPIC system, January 1 of 2017. We have so much data and we're getting ready to pull our data and look at it. And so I'm hoping we're gonna see some pretty amazing stuff once we do that. And I know that we can always look at our wonderful scientists who are leading the way to bring us along. So I thank you, Mike, for what you say, because I believe that's where we're heading.
Thank you very much.
Trent in Australia has a question.
Hi, Mike. Yeah. Thank you for a wonderful presentation. How close are we to developing, and I know you touched on it in your presentation, a risk stratification tool for preventative cardio-oncology?
You know, I think we're on our way. I would say that, you know, we are not, I don't think it's on the immediate horizon, but I don't think that it is also something that is incredibly distant. I do know that there are quite a few individuals who have some pretty interesting studies, some different, you know, big grant supported studies to specifically look at some of these risk prediction models, both in patients with active cancer, but also particularly in some of the cancer survivorship populations. So for example, there's a person by the name of Eric Chow up in Seattle who has several grants that are looking specifically at this. So, I mean, my thought is probably we're going to have some pretty decent data in probably the next 5 years that will help us to guide some of the decision making.
Thank you very much.
May I comment on that, Trent? So good to hear from you from Australia. I have
Hi.
Steve, I can't remember his name, but we've been talking and I've been mentoring somebody till COVID. I'm going to come to Australia because that's on my bucket list. But I will tell you that we were blessed. We had a conversation with Dr. Herman at the Mayo Clinic, and he had published the start of a cardiac risk back in 2016 based on data from 1960 to 19, what was it? I can't remember the exact date, but as far as 2014, and based on that, they came up with this risk stratification. And so Dr. Rao and I had dialogue with him, and we were going to use his, and we have used it as a foundation for our patients since the start of our clinic. And so every one of our cardio-oncology patients that we have seen or that we have followed has had one done. We have updated it according to the new guidelines. And just as I mentioned, we're getting ready to pull that data. So 2017 and to today, we're going to have a lot of data. So hopefully we'll be able to see things that maybe will bring to your point. But what I would say, start with something. You know, there's a lot of good ones out there, and it does really is helpful, and it is a tool to help you have that collaborative dialogue with oncologists, and they can see it, and when they see different outcomes, they're going to embrace it.
Thank you so much, and we look forward to seeing you in Australia.
Oh, I'm coming. You'll have to let Steve know where you live, because yeah, you are on my bucket list.
Thank you.
And Janet Selly, I think, has a question.
Yes, and I want to come to Australia too. So I just wanted to say thank you very much. Exactly, we can do that. But Dr. Fradley, thank you so much. It was an excellent layout and an excellent description of past, present, and future. I am just curious, with our monitoring in our program in Orlando, we do monitor folks with echocardiograms every 3 months that are getting anthracyclines and the HER2 therapies. What are your specific thoughts on radiation therapy in addition to, do you think there's a synergistic effect for cardio-oncology? Do you in Pennsylvania monitor folks more closely who are following up with radiation therapy? Just curious on that.
Yeah, it's a good question, and I think that there's definitely synergistic effects, particularly if you're speaking about radiation to the left side, or radiation that impacts the carotid arteries, or patients that are receiving mantle cell lymphoma. So, our mantle radiation. I'm sorry. So there are certainly synergistic effects, and the ASCO guidelines actually suggest that patients who even receive lower doses of anthracyclines, who are getting concomitant radiation that may affect the cardiovascular structures, are at a higher risk. Now, that being said, at least during surveillance, during active cancer therapy, we don't do anything different than what is currently recommended, which, for example, with trastuzumab is, the Q3-month echoes, which, in and of itself is its own, kind of controversial discussion that you can have debates upon. But we don't add anything beyond the traditional simply because someone's getting radiation. Now, post-treatment, and once they get into survivorship, I do think that the radiation exposure impacts some of the long-term evaluations. And certainly, if patients have received anything that's going to impact their carotids, they should be getting a carotid ultrasound. Usually within 5 years of the completion of their treatments. If they've received radiation to the chest region, particularly the left side, we add some form of coronary assessment, whether that's a stress test or a calcium score or something of the like, again, within about 5 years of the completion of their therapies.
Oh,
thank you very much.
Janet, I'm going to give a follow-up on that because I just have to, full disclosure, I am a cancer survivor. I actually, in 2008, went through my cancer journey, and I had non-Hodgkin's lymphoma, and it was in my face. And so I had radiation, and I do have my carotids checked now because I'm under the care of an excellent cardio-oncologist named Vijay Rao. However, I don't think people understand radiation, and I think there's a large gap there. The reason we're hiring we're hiring another navigator so we can focus on a proactive surveillance program. And we're going to be, because we just now treat, the complications, but I will tell you, we have moved to, if they have chemotherapy treatment, we are doing a echo and an EKG and an assessment prior to any radiation treatment. And then additionally, when we move to our radiation, one of the things that they were trying to get budgetary acceptance to put a calcium score within the planning CT so that we could actually get a calcium score and use some automatic referrals based on what just Mike just referred to about what is recommended by the guidelines, the 2 rays, mean heart rates to the heart. We're going to be working with a physiologist, and I'm very, very excited because nobody told me. If it wouldn't have been for me going in this program, I would have never had my carotids checked. And I will also tell you I have a bicuspid aortic valve, and nobody ever did an echo on me. It wasn't until I met these guys up here and they said, you probably should have an echo. So I hope things move in a positive direction, and we will be having some proactive data down the way too.
Thank you, Carrie.
And then I just want to say one other thing I just thought about, which is this sort of piggybacks off of what Carrie just said. A lot of these patients do have CT scans of their chest, so we try to make sure that we look at all of the data that they already have, and look for any coronary calcifications that may already exist, because again, I think that adds to how we may manage them from a proactive standpoint. So making sure you're looking at those CT scans is really important. And I also think this is yet another opportunity, again, where you start talking about how nursing can play such an important role in the clinical care of these patients. Not only ensuring that so we're adhering to the recommendations that exist either societal wise or at least within our own institutions, but also then talking to patients after the fact. You know, I will often have situations where I'll mention to a patient that they should start on a statin because they have coronary calcifications and they've received radiation to their left breast, or maybe they're an esophageal cancer survivor and they received esophageal radiation, which also impacts the heart. We don't often think about that. And the patients are frequently reluctant to start a statin because they've been told their cholesterol is, quote, okay. And, you know, we don't necessarily have a lot of opportunity in the clinic to sit there and go through the pros and the cons, but it's a great opportunity for nurses to follow up and talk a little bit more and, you know, maybe address some of those concerns or hear a bit more about why the patient is reluctant.
And Masood, do you have a question?
Yes, thank you for a very good lecture. I want to ask you two questions. One of them is suppose that my patient have moderate to severe aortic stenosis, or for example, mitral stenosis. Can I give okay to my patient to go to radiotherapy, or should I treat my patient before treat cardiac treat valvular problems before the radiotherapy? And the second one is also for chemotherapy. For example, my patient have severe CAD, or not, of course, myocardial infarction, but severe stenosis in one or two coronary arteries, and he or she want to go to chemotherapy or radiotherapy. Is the survival can affect my treatment? For example, my patient have survival for 6 to 1 year. Can I say that when my patient survival less than 1 year, then I cancel the angiography and just supportive care? I want to know your opinion, your answer.
Yeah, those are both really, really important questions, and I think that they are questions that we all struggle with on a regular basis. You know, I would say that for you know, the first question always is, you know, the urgency of the issues. So, you know, are you talking about, you know, a patient who's having an acute coronary syndrome and they have a relatively indolent cancer? Then certainly you'll want to talk more about treating their coronary disease first. Or, you know, do they have relatively stable findings that, you know, obviously require some level of treatment or intervention, but that can be delayed a bit until their cancer is more appropriately treated. So those are the first questions that we often, you know, address. What I would say specifically to what you asked is, one, for the radiation, I would say that I would probably have the patient, you know, undergo their radiation treatments before intervening on their valves, mostly because the you know, the radiation has more of a long-term impact. So, you know, you're not going to really worsen the severe valvular heart disease in the acute setting. It would be something that's in a more delayed fashion. And, you know, once you've replaced the valve and you kind of replaced the substrate that was affected by the radiation post exposure, then it's not like you continue to have impacts after you replace the valve. So as long as the patient is relatively stable, I would say treat first and then fix the valves later. The issue related to ischemic heart disease and potentially acute coronary syndromes is definitely a complicated one, and one that we struggle with all of the time. And usually what we have to do is, you know, we oftentimes have to try to support these patients as much as we can in the short term to get them through their acute issue, their acute logic issue, and then intervene later. So I'll give you a good example of a patient that we had taken care of who had APML. So ultimately had good long-term survival, but in the short term was very, very sick from his leukemia and also presented with an acute coronary syndrome. His platelets were, you know, less than I want to say they were right around 10,000. And he had evidence of multivessel coronary disease. So we ended up treating him medically and allowed him to get his induction chemo with arsenic and atra. And ultimately, he did well. He had response. His bone marrow showed response. And then once he had that first initial response, we then took him actually for cabbage. So I think there's a lot of data about trying to stabilize in the short term and then doing the more definitive treatment once their kind of acute issue is relatively stabilized.
I know, but how about survival? Is the survival can affect my treatment? For example, in poor survival, less than 1 year, I omit the angiography and I cancel it. And so I say, for what? If you don't have any pain, no angiography, no coronary, just medical treatment, no procedure, and you can come to your oncologist and just get chemotherapy treatment. Is it true or not?
Yeah, I think that's certainly true. I think that, if a patient's overall prognosis is really poor, then I agree with you. I mean, if the patient is not having any active symptoms and their quality of life is okay, then I don't think there's a really compelling reason for us to be doing any interventions. In these individuals that have, a year or less of overall life expectancy, my philosophy is, you do whatever you need to do to improve quality of life, because you're probably not going to be doing anything to add. From a cardiology perspective, we're not going to be doing anything to actually impact quantity of life. So I wouldn't treat outside of medications unless you were forced to because of a symptom-driven finding.
Yes, thank you.
I'm just going to add, as a nurse, this is one of the things that I work with my pharmacist. Exactly what Mike has shared with you, but you need to think about fluid management because these patients, depending on whatever regimen they're on, it can affect them and they might need some help just to get the additional fluids off. And so I've had probably several discussions this week about this issue. So that's just another thing to think about.
I think maybe we have time for one more question or comment. Avi Guha, looks like you had a comment or a question.
Can you hear me?
Yes.
Hey, Mike, great presentation as usual. I had a question for you and one for Carrie maybe. So the question is, like, you mentioned that obviously research is needed, like you showed the slide from Hart, which showed about nurse navigators and how they help in general with any kind of clinic. So what do you think would be sort of the type of research we'd need to do to show sort of definitively that this is a good idea? And then the question for Carrie is that, obviously this is an up and coming and new field still. So how have you, outside of obviously going to so many tumor boards, this is incredible, being able to sort of justify cardio-oncology and grow it from the nursing standpoint? Thank you.
Hey, Avi, how you doing? Again, I think those are really important questions. And, I think that one thing I've learned just over, the last decade or so is, there are like some really, really phenomenal nurse researchers who are, again, really kind of looking into these concepts of sort of nursing integration and nursing care models. And I think probably partnering with some of these kind of thought leaders in the field of nursing delivery would be really useful in sort of identifying and developing some of the right research strategies and developing some of the right research questions. Like, for example, there is a person, her name's Leah Buck, who does a lot with heart failure, but she does a lot with sort of end of life and kind of dyad caregiver relationships. And I think that, we as physicians get very kind of focused on, these kind of hard disease outcomes. What's mortality? What's our impact on mortality? What is our impact on, does this treatment impact, their 6-minute walk test or something? But there's a lot of, but the thing is that when you start talking about, let's say patient-reported outcomes, there's a lot of things that patients care more about than what we as physicians always think about. And that's where I think we start to kind of integrate nursing research into these models, because they can really start thinking about some of these kind of patient-reported outcomes and how those patient-reported outcomes can then translate into benefits for, say, a health system. because if the patient-reported outcomes are better, then that is good from a satisfaction standpoint, which helps the health system, and you sort of start to see all of the downstream improvements that can come with it.
So I'm going to jump on because we don't have very much time. Abby Guhal, please get my email from Steve, and I will be delighted to talk with you about it. I'm going to just thank you, Mike, from the bottom of my heart. I can't even tell you how much I appreciate what you've done for us. And I'm going to tell you that we have some amazing presentations next one in May, and you can find out from Steve. Actually, Anacita Fidel presenting what a cardio-oncology person can look like, a nurse can look like from MD Anderson, myself as a community-based embraced by both cardiology and oncology, and Janet Seeley from down there in Orlando. She works with Pamela Guerrero, another amazing cardio-oncologist. And following that in June, you should mark it on your calendar, 6/17. There is going to be a presentation. I hope you can join Dr. Fradley, because you are one of the authors. It's going to be the orals. I don't know what the name ended up being. It's going to be Vijay Rao and our amazing pharmacist, Dave Reeves, and any of the others. I believe Dan Lenihan, Susan Dent, Mike, you can help me. And it's going to be on how to look at orals. Can you add to that, Mike?
Yeah, no, this is that's great. It's an incredible project that really was the brainchild and completely spearheaded by Vijay. So, you know, all the accolades go to him, but it's really an opportunity on how to appropriately evaluate and monitor for toxicities in patients who are taking oral TKI-based therapies. And it's really meant to be a primer, especially for the practicing community cardio-oncologist. So not necessarily in like the ivory tower, but how are you going to do this, you know, in a normal, regular environment on a day-to-day setting?
Thank you so much, Mike. And wait a minute, when the last one is in July, we're going to have, I can't remember her name, you'll have to say, from Canada. What's her name from Canada?
Don't remember.
Oh my goodness.
Sorry.
Anyway, an amazing woman. She's knocked it out in Canada as a nurse. We're going to listen for her, and we're going to have Vicki Chambers from London, England, who works with the amazing Alex Lyons. And so please mark your calendar. Thank you for joining us. And Steve, take it away.
Yeah, just say thank you both so much for your presentation. Excellent presentation, so helpful. Thank you all for the discussion, and we will be with you 1 month from now for another nursing-focused webinar. So thanks for joining us today.
Thank you, guys. Have an amazing day.
Thank you
very much.
Thank you, everyone.
Bye.
Thank you, everyone.
Thank you.
Thank you.